Yeah. Hi, thanks for having me. I am Kevin Hovde. I'm a physical therapist with Empire Physical Therapy. I've been working for about 8 years as a treating therapist, and I work at a clinic that sees mostly um, outpatient patients, a high volume of post-op patients. So I see a lot of these post-operative ACLs, meniscus. I honestly don't see a ton of this type of surgery, the TGCT. I have seen a few. And can you guys hear me in the back over there? Okay, thank you. Sorry.
There.
But yeah, I'll be diving into hopefully some content that is digestible for both patients and practitioners. Plenty of time for you guys to ask questions at the end. And then I'm also part of that roundtable discussion if there's anything that comes up, if we need to kind of collaborate on anything with the physicians as well. So this is my family, my wife and two kids. They between that and work keeps me pretty busy here. So the role of physical therapy is what I'm going to talk about, and really optimizing range of motion, strength, and then function for the long-term benefit. I do dive a little bit into what it is, and you guys have probably heard for the last three presentations that you know what it is. Locally aggressive tumor affecting soft tissues around the joints, lead to inflammation, swelling, and joint damage. So I thought this was a good visual. I think we've seen a lot of like cellular visuals. This is the knee, and I'm going to touch a little bit more on the knee, as that tends to be the joint a little bit more affected and has a little bit more of the functional deficits when you're kind of dealing with this. PT does not affect the tumor itself, and it often follows surgical intervention. But as Dr. Keaty touched on, there is that pharmaceutical approach, so drugs that treat the tumor. And I would assume, and we can talk about this on the roundtable, but I assume that the drug trials go along with PT, right? Some way to improve your motion, improve your strength, and maximize on your ability to just live out your life. So we often see these patients after a resection of that tumor, but prehab can be very beneficial. So that's rehab that is done prior or leading up to a surgery. Research can show that we're going to have better postoperative outcomes and an early function following a surgery if a patient can come in with a really good knee range of motion and really good quad control. And those are really the two big things that we're going to touch on postoperative. And so after surgery, rehab is super important to address these deficits and improve your function so you can get back to what you want to get back to doing, right? So at the end of the day, that's my goal. That's our goal is to allow you guys to live full, healthy lives, reduce your pain, and manage. So early intervention improves objective and qualitative outcomes. Following a knee surgery, the most improvement you see is in that first 12 weeks. And so my recommendation is always start PT as early as your surgeon or physician will allow. If you delay this too long, you are going to miss out on a really like imperative window to get your function back, to get your motion and your muscles back. So ideally, this first PT session after surgery is going to start in the first week, sometimes even the very next day. I mean, I'll have these patients, they'll still be wrapped up in surgery. They'll have a little bit of that anesthesia going on through their system, maybe a little bit loopy, but we start right away and we hit the ground running because that's where you're going to get most of your benefit is that really early rehab. So as soon as you can get the knee moving, as soon as you can use some of the modalities we're going to touch on to reactivate your quad, the sooner you're going to be able to walk, navigate stairs, bike, hike, whatever it is that you want to get back to being able to do. So key impairments prior and after surgery, pain and swelling in the knee, reduced range of motion, muscle innervation, especially your quadriceps, so that thigh muscle, and then a decreased strength and power. And as I mentioned, these impairments lead to difficulty with walking, squatting, stairs, getting in and out of your car. So we want to address them. We want you guys to be able to live normally. So the rehab priorities, and this is kind of in order of how I present it to my patients. Manage your pain, control your swelling. In bolded there, you'll see restore ROM or range of motion early. So get the knee moving as early as you can. And then muscle activation and progressive strengthening. I like this graphic here. It's a knee range of motion. It kind of tells you at what amount of knee flexion do you need for functional tasks? To go up and down stairs, you need about 90 degrees, so a right angle. To get up from a chair, about 105 degrees, and then to ride a bike, north of 110 degrees, so that more flexed angle in the knee. So we'll start with the managing pain and swelling, and these are just a list of the few things I really like to employ with my patients. Mat, I'll touch on really quickly. This is something I use on a lot of my post-op knees. It's a treatment that combines TENS, so electrical stimulation, with a lymphatic massage. And the role of that is really to promote fluid exchange and be able to push swelling off of the knee and eventually be picked up by your kidneys and kind of flushed out. And I'll do that. It's like a 10-minute treatment. I kind of do it at an angle, so we're using gravity to assist draining swelling off of that knee. Compression, some type of compression garment, ice elevation, ankle pumps, and really more than ankle pumps is just like your early post-op rehab, where you're getting this rhythmic contraction and relaxation of your muscles. And essentially that's creating a little bit of a muscular pump to push some of that swelling and fluid off of your knee and again be picked up by your body and let your body do what it naturally does, which is help kind of flush out that. And then avoid overdoing it early. You might have some of the good pain medications in your system and feel like you can go and walk a mile, walk all around the mall, do something crazy. I see that a lot. They'll come in the next day, they say, I'm swollen, I'm sore. I'm like, yeah, I know. Yeah, you did it too much. So try and avoid overdoing it early. That's not complete bed rest, which I'll touch on in a little bit. But yeah, you don't want to go out and just crush it right after a surgery. The importance of early range of motion. This is what I highlighted. This is the really important thing, is restoring the knee range of motion. And you can extrapolate this out to the hands and the other areas where TGCT affects, but it's going to prevent stiffness and that fibrotic tissue, scar tissue from building. It's going to improve your long-term outcomes. It can also reduce risk of chronic limitations. Um, while restoring both flexion, so knee bend and knee straightening are important, restoring full extension or even hyperextension in the knee is imperative. This is where I really focus a lot of my patient education and time is restoring full knee extension and getting the knee fully straight. If we can't get a fully straight knee, it could lead to an increased likelihood of anterior knee pain or pain in the front of your knee because your quadricep is inhibited, so that thigh muscle isn't supporting the knee. It's changing your gait, so you're walking differently, which can lead to increased pressure on the knee or elsewhere, maybe above or below that knee in your hip or ankle or on the other side. And it just affects your mechanics with being able to do squats and stairs. And so getting that full extension as soon as you can get it is huge. All right, this is where we start day one, and we really don't stop maintaining that motion throughout the whole course of rehab. So restoring and maintaining your motion. And I actually have a little typo highlighted here, so it really hits home here, but 3 to 5 times per day, 7 days per week. So this is daily mobility work after surgery. And like I said, maybe starting even day one after surgery, that's a lot. All right, 3 to 5 times a day, 7 days a week, that's a lot, but it's frequent low load movement. You're not necessarily going to the gym and crushing a hard session 3 times a day, but you're doing these gentle stretches that I'll get into a little bit later. You're doing that often throughout the day, and you're keeping the knee moving. You're getting into these bent positions and straight positions over time and over the course of the day to prevent that scar tissue and that reoccurrence. So that assists with the stretching of the tissues. It's called the creep phenomenon, but like a lower load, so not a really intense stretch. You're not cranking on the knee, but that lower load held for a longer time has been shown to really improve the motion in the knee. And then avoid prolonged activity, right? So that's why I said not overdoing it, but it does not mean bed rest. We don't want you sitting in the bed with a towel underneath your knee for 2 or 3 days. That's going to lead to a really stiff knee and an uphill battle in your rehab process. We do want you to get up and move throughout the day, alternating between sitting, standing, laying. It's okay to walk around as long as you're not going on hikes within that first week. All right, mobility work, and we can go over some of these. And if you have questions after, I can talk about some of these exercises. But we have flexion-based range of motion. and extension-based range of motion. I typically go in that order, where I'll start on all the knee bending exercises first, and then I'll work into all the straightening exercises next, and then follow that up with quadricep activation and early strengthening. So flexion-based motion exercises, you're going to get your heel slides. If you have like an exercise ball, you can do some ball curls. Um, just stretching it on the edge of the bed, almost letting it fall into that normal seated position. And then as you get further on, a quad stretch and quadruped rocking, where you're really working into these deeper knee bends to try and keep that joint stretched out, try and prevent that fibrotic tissue from setting in. Uh, Conversely, the extension-based range of motion is everything trying to get the knee straight. So you're going to stretch everything on the back side of your knee, so your calf and your hamstring. Extension prop, which is going to be one of the most important things you do, and that's basically propping a towel or a bolster, something underneath your heel, and letting your knee just hang straight with nothing behind it. And we're trying to let gravity essentially pull that knee down into a straight position right through there. And that's a very long duration stretch. I typically educate patients on holding that to start for 3 minutes, but working their way up to 10 or 15 minutes at a time. And you're sitting there and you can do other things. You can work, you can watch TV, do homework, whatever it is. But as long as you're in that position, you're letting gravity assist you, it's going to really benefit restoring that motion. And we typically start with passive range of motion. So kind of these passive stretches where you're just stretching it out and then work into more active or active assisted range of motions. So I kind of phrase it in the way that you stretch it out passively and then you use that new range that you gain from your stretches to help really solidify and lock in some long-term benefit. So it starts passive, then you go into some of your active and active assisted stretching. So at the bottom here, you'll see, I don't know which one makes the little red pointer go, but there. This is the extension prop I was talking about. So that towel roll sitting underneath the Achilles or the heel. And really you should have space behind the back of your knee here, letting it fall. And on the top right here, this is a CPM machine, which I think that was on the question that Sydney gave me. Continuous passive motion, it's a device you hook up onto your knee, and it just moves slowly into a bent position all the way straight. It keeps going like that. Again, it's a passive stretch. I don't use it a ton in my own clinic, but I have used it in other clinics that I've worked at before. It can definitely be beneficial. It helps supplement some of the other things you're doing. And so definitely a tool, especially if your physician recommends it and you can get access to it through your insurance. I think it's definitely a tool that's going to help get that motion back. Okay, now we're going to dive into, so we kind of addressed the pain and swelling and then the motion. And now we're going to get into the muscle activation. So the quad activation challenges. The quad is really kind of the king when we're talking about knee surgeries. The swelling and trauma of that surgery almost always causes inhibition. So it kind of decreases the ability of that quad to fire and activate. It's almost a defense mechanism by that body, right? You have a surgery, the knee and the body recognizes that there's a trauma, whether it's a planned trauma, but it kind of just shuts down. And so the body can be amazing, but this is kind of a stupid thing for the knee to do. So we need to counteract that. So when we have that muscle inhibition of our quad, that leads to weakness, decreased control in the knee, and patients or you guys might even report feeling unstable, or you kind of lack the trust in that knee to support them during walking, squatting, sit to stand stairs. Super common after surgery. We see it all the time. It's one of the things we really try and address early and then maintain. So there's a few early activation exercises. One thing that I really do with almost all my post-op knee patients is neuromuscular reeducation using electrical stimulation, so NMES or EMS. And then once we kind of restore that function, you get into more progressive strengthening. So starting a little bit lower level and going from there. So NMES overview, neuromuscular electrical stimulation. Basically, you put electricity on your muscles, you crank up the machine, and it forces the muscle to contract for you. It bypasses inhibition or signals from the brain and forces that muscle to fire. And it's also non-selective. So it's going to recruit all the different types of motor units and that you have, including the fast twitch fibers underneath that are going to be important to help support us in everyday tasks. These are super common. You can get them on Amazon. You can get any like medical device store. I think they even have them at Target, honestly. Um, I use it typically the first session, and I usually combine it with some type of exercise once they gain a little bit of confidence. I think it's really important with that mind to muscle connection to when you place the electricity on this muscle and you crank that machine up, it's going to make your quad contract. But if you can think to actively do that with the machine, you're gonna double down on that benefit because you're going to be able to then recruit that muscle better. You're going to learn how to recruit that muscle better when you don't have the machine. And this is one of the things where a little bit of discomfort is fine for me. The higher intensity for a stronger contraction, the more intense, the better. So I try and turn it up to where they can barely tolerate it. Then I go down a little bit, and then we try and work from there. I think the next one is actually a video. Now this is actually my knee. I had ACL surgery. I did not have TGCT. This is I think 2 days after my knee surgery. I had this. Machine on. I don't know if you can see muscles twitching through there. I'm really struggling to get a really strong knee contraction out of that. It just wasn't wanting to fire. I had a surgery a couple of days ago, but immediately I'm putting these electrodes on the machine, which isn't pictured there. I'm turning that up as much as I can tolerate, and then I'm trying to contract my muscle with it. And if you have one of these at home, this is something that I also have you do 3 to 5 times a day. The more repetition, the more you're going to learn from that. So early muscle activation, you start with the basics, quad set, just activating your quad. You move that into a more dynamic leg raise, terminal knee extensions, which is kind of using that quad to get that knee into full extension. A really important part of our walking is terminal knee extension. So be able to walk normally without a limp or a hitch. And then knee extension isometric, and then progressing into what I consider mid stage, which is wall sit, maybe a leg press, squat, step up, step down, and actually kicking out onto a knee extension. And I have early mid. I don't have timelines on here. Every patient's going to be a little bit different on their trajectory and the way that they progress through their rehab. And even with TGCT, right? It's there's going to be hills and valleys. You're going to have good days, bad days, and so you can't necessarily put an exact timeline on it. Um, I just really look for them to master the early, and then we'll progress into the mid stage. And there's a few things you need to get also before you get into a squat or a step up and step down. As I mentioned before, you need to have that motion to do it. So you got to get the motion. To get the motion, you have to manage your pain. Once you have the pain and motion back, then we get into these strength movements. Another modality that I like to employ with my post-op knees is BFR, so blood flow restriction. I don't know. Has anyone heard about this or done it themselves as patients? Sarah? All right. So this is essentially putting a tourniquet on your leg, and then cutting off the protocol for this is 80% occlusion for the lower extremity, and then you perform exercises while this tourniquet's applied. Not exactly the most comfortable thing, but you get a lot of benefit from it. So you're allowed to build strength without putting increased strain on the tissues in the joint. Some of the research I've read shows at 20% of your max effort, you get as much benefit using the BFR as you would doing 80% of your max effort without. So it's allow us to train and strengthen the muscle without doing too much work and putting too much strain on that joint, which, as we mentioned, sometimes these joints become a little arthritic and they're not going to tolerate heavy weight. They're not going to tolerate a really heavy leg press or a squat. So you use the BFR to work around that. And the next slide here, this is the BFR machine that we actually use. There's a couple different varieties of it. But like as I mentioned, it's useful when heavy loading is not tolerated. When we can't really load a squat or a leg press, we use the blood flow restriction to get those strength gains and work around your pain and an inability to kind of load that joint. So it really works to challenge the muscles metabolically. So it removes oxygen from the system, which then forces that muscle to work in an anaerobic capacity, which is how muscles need to work to grow in size and strength. And so it's super useful in early rehab. When you get to a point where that joint can tolerate heavier strengthening, that's when we move into the heavier actual strengthening part of it. As far as strength progressions, I typically like to start lower load, higher reps. And when I say that, I'm talking about like 3 sets of 15 to 20 repetitions. So you're doing a lot of repetitions, but you're not necessarily doing a super heavy weight. For the early rehab, when you get into the later stages and you actually want to build the strength to support the joint, then you drop your reps and you start working into higher resistances, and then you're getting to your kind of consistent 3 by 10 or even more like a 5 by 5, like 5 sets, 5 reps heavier to build your strength, to build your power back. And this is all going to be dependent on patient goal, right? Do they want to hike? Do they want to play sports? Do they want to cycle? What is their goal? What do they want to get back to? That's up to the physician and the PT to collaborate on that treatment plan and what we prescribe as far as exercises. And then functional strength, progressing into that. So a leg raise is not necessarily super functional. It's important to do. It's important to master that, but we really want to tie that then into function. So then we would need to get into your squatting, your step ups, your deadlifts, things you're going to do on a day-to-day basis, right? And deadlifts, you're not going in, you're lifting 250-pound deadlift, but you might have to bend down and pick up a bag of groceries or your daughter or whatever it is. And obviously stairs just for community and household mobility. Your focus is going to be on the quads and hips. That's really what supports the knee the most, and go from there. Also had questions about manual therapy. This is a little different than massage therapy. Manual therapy can be a little bit of just soft tissue mobilizations, which is going to be similar to the massage, but also joint mobilizations and other techniques. I'm going to jump to the bottom bullet point there. This is useful in supporting an exercise-based rehab approach. So really the exercises and what you do at home outside of PT is going to be the most important. All right, that's the meat and potatoes of your rehab. But the manual therapy can really address some secondary issues. It can decrease some of that muscle guarding you'll get, so you feel really tight through your quad or your hamstrings. You do work some soft tissue massaging through there. You maybe place some cups on it. Has anyone done cupping in here before? Yeah. We dislike, whatever it is, but it can help kind of decrease the muscle guarding. And then that allows you to more effectively stretch that joint out. It can also have a pain relieving effect. So you come in, you feel stiff, you feel painful. I'm able to do, 5-10 minutes of manual therapy and I can get that pain level down. You're then going to have an improved tolerance to rehab and benefit more from the strengthening and mobility exercises that I prescribed to you that day. So like I said, the soft tissue mobilization, that's going to help muscle tightness, movement quality too. You might come in and I'll say, all right, show me a squat. Doesn't look great. You're shifting away from that knee. I'll do some soft tissue work and you just generally feel better. It takes away maybe that front knee pain that you're getting. Um, and and then allows us again to have a more optimal session that day. And so I typically do it a little bit gently. I don't want to flare this up. If a patient responds more to a heavier pressure, that's where I'll start working into a little bit heavier pressures and a little bit more intense. And then where is this typically performed? Quad, IT band on the front side. That's usually where I get a lot of the benefit. Also, even just like work right around that kneecap, kind of right where that tumor was removed, kind of in underneath the patellar tendon, just because I think there's that pain relieving effect through it. And then if they're tight, getting into a fully extended straight position, that's when I'll really focus on the backside, getting into hamstrings and calves. And then joint mobilization. So the two joints we're really talking about is your patellofemoral joint, so where the kneecap sits at the end of your femur, and then your tibiofemoral joint, which is the meeting of your thigh bone and your shin bone. And this is where you're going to get really tight. This is where you're going to develop some of that scar tissue that's going to prevent you from getting full motion. And so there's a couple different techniques that are really going to be beneficial, just mobilizing the kneecap side to side, up and down to help with your flexion and extension, and then same with moving the shin bone forward and backward. You typically use this when the swelling is more controlled. And again, this is something that probably needs to be done by a PT. I wouldn't want anyone else necessarily mobilizing that knee like at a stretch lab or anything like that. And then putting it all together. So what does a rehab session look like? This is my thoughts. This is how I design my rehab programs. I typically start with some type of warm up, and then I do like to get into that manual therapy. As I said, I think this helps improve the movement quality. It decreases your pain, and it sets you up for success when you get into that mobility and muscle activation work. And then mobility work comes first. Start with your flexion, then you get into your extension. Once you get full extension, you're more able to activate that quad muscle specifically. So that's where that muscle activation comes in. But that also includes activating your hips, doing maybe some bridges or some side lying hip abductions. And then if you're ready for it, this is where we get into the strength and the loading phase. And this is going to be more your squats, your step ups, your leg press, and at the end, accessory work. One thing I really like for accessory work is balance. If we're talking about knee rehab, I think the ability um, to balance on one leg shows that you're aware of your knee and its relation to the rest of your body and in space. It is what we call proprioception. And you lose a little bit of that ability to control and understand where your knee is after surgery. And so this is where I usually work into some balance work. And again, life happens in single leg stance. So every time we walk, there's a period where we're on one leg. Anytime we can prevent a risk of falls, that's going to be beneficial. I know we talked about like total joint replacements. Definitely don't want to fall after total joint replacement. So this is where some of your balance work comes in. When can I slide? So I think a lot of questions I get from patients after knee surgeries is, hey, when can I do this? And I'll sometimes even bring this up on day one of like, what questions do you have for me? What are your when can I questions? And let's try and make a plan. Let's try and make these your goals. So if they're like, when can I go up and down stairs? Right? I have a 2-story house. I'm staying on the couch in the first floor right now. And I'll say, well, you need about 100 degrees of knee flexion to be able to effectively go up and down stairs, and you need to have adequate strength. And so for me, that's doing a straight leg raise without any knee bend. So that tells me you have fully straight knee. That tells me you're activating your quad enough and you have enough strength to tolerate going up and down the stairs. And so then I'll set goals. I'll say, all right, you have 90 degrees of knee flexion today. If you want to go up your stairs, let's see me next week. Let's get to 100. And now they know why that's a goal. And now they know what that means. And they know what their homework is and why they're doing it. So it kind of ties it all together. I want to walk normally. Well, your knee's not straight yet. In order to walk normally, you have to get that terminal knee extension, that full knee extension that we are talking about. So your job is to do that extension prop 5 times a day, 10 minutes at a time. So you're going to give me 60 minutes, 50 minutes of knee extension props so that you can get a fully straight knee. And when you have that fully straight knee, we'll work on your quad and then you'll be able to walk normally. Driving, I get that a lot. I think that depends on right or left knee, whatever you're working on. But again, you need to be able to bend your knee enough to get it in the car, and then you need to have enough confidence moving that knee from side to side. Biking, as we show, that's about 110 degrees to get back to cycling. So again, you can kind of tie that to your goals and why you're doing these stretches and exercises. And then return to exercise and recreational activities. When can I? I'm not sure. It's going to be based on these kind of objective and qualitative assessments. And again, this is also going to be tied in with your visits with your doctor and your physician. Are we all on the same page? Are we going to clear to get back to playing basketball or swimming or going on your hikes? And how can I? And we can dive more into that if you guys want to at the end of like, how do I go up and down the stairs? How do I focus on my walking? I'm not going to touch on it necessarily right now, but I'm happy to answer those at the very end. And then home exercise programs. I typically see patients twice a week, maybe 3 times a week after a knee surgery, depending on how their knee looks. So they're only seeing me 2 or 3 hours out of their entire week. So that's a drop in the ocean. That's not a whole ton of time that they're actually having me look at them do their exercises. So this is where I prescribe them home programs for them to perform. Again, sometimes that's 3 to 5 days a week that you're doing your stretching, but it's essential for the progress and because there's a risk that you're going to get stiff. You're going to have a recurrence of some of this TGCT want to set back in. So to prevent that as much as we can, daily home exercise program. Every single day you're doing something, or once you get further out, you're doing something 5 or 6 times a day. And so that's daily range of motion, and that's some of the strength. And this will change whether you're day one post-op, week one, month one post-op. And then tailored programs. I think this is something we probably need to be a little bit better with just as PTs in general is individualizing to the patient needs. And that starts day one. So if you guys have had PT, I'm assuming a lot of the patients in here have had PT before. Make sure that PT is asking you questions about what your goals are. What do you want to do? Why are you here? What do you feel like this is affecting the most? And how do I get you there? And then their treatment and that home exercise program should reflect that. And they should be able to educate you on the why behind that. Obviously, it's going to be adjusted based on symptoms. There's not always a trend, a perfectly linear trend line in the right direction. So sometimes you have good days, bad days, good days, bad days. As long as you're consistent, though, I relate this almost to like investing in a good stock. Over time, you're going to have increasing benefit, even if you have a really good day and then a flare. But over time, if it looks like it's trending in the right direction, we're doing the right thing. But it's got to be consistency with that. And then long-term management, just maintaining your motion and strength. This might be something that you're just doing throughout your life. And it might be something that you monitor your symptoms. You start to get a little bit more stiffness, a little bit more pain. Maybe it's swelling. All right, let me get back into some of these rehab things I know. So hopefully from your rehab course, even after we kind of discharge you to a home program, you take some tools that you're able to put in your toolbox and use when you do have maybe a setback. So you know, oh, I'm starting to get a little stiff, I'm starting to get a little achy. Let me do these 5 or 6 things. Let me monitor my symptoms, maybe adapt my activity a little bit and try and get me back on track here and try and prolong the life of needing to go on and off meds or MRI surgery. And so there's a high recurrence risk and may require long-term management rehab. So really a goal for me is also to set patients up for success where they're not going to need me always. They're going to know what to do. They don't need to keep coming back to my clinic because they have the tools they need. And so take home messages, early range of motion is huge. If you're going to do anything in the first week, start moving that knee. All right, both flexion, but especially get your extension back. Once you have your motion, then you start to restore that quad activation. You're going to use your stim and BFR appropriately, and then PT hopefully is going to support your long-term function. I'm biased. I'm a PT myself, but I always recommend it. References right here.